Good morning, everyone, and welcome to another session of TIRO MDS. I'm Mark Urken, head and neck surgeon here in New York at Mount Sinai, and we are joined this morning by a really wonderful group of folks who are going to discuss some fascinating cases on this tumor board. We do have a stand-in for usual Dr. Mike Tuttle's role in running this tumor board, but there has been a coup, and he has been, at least for this session, replaced by Dr. Erik Alexander, who's chief of thyroid section and in the Division of Endocrinology at the Brigham and Women's Hospital in Boston. He is a professor of medicine and associate dean for medical education at Harvard Medical School. He has a special interest in the treatment of thyroid illness, particularly occurring during pregnancy, and he has held leadership positions at the ATA and has participated actively as a member of clinical practice guidelines committees. Our cases this morning are being presented by Dr. Nicole Íñiguez-Ariza, and I apologize for probably not the best pronunciation. She is an oncologic endocrinologist at the Thyroid Clinic in the National Institute of Health at Mexico City, where she cares for patients with advanced thyroid cancer. In addition to her training in Mexico, Nicole also spent 2 fellowship years at the Mayo Clinic, and she's actively involved in both clinical care as well as clinical research. And so with that, I'm going to let Erik take over the platform here. Erik, it's all yours.
Thank you, everyone. Thanks, Mark, and welcome, everyone. Good morning and good evening, depending where you are in the world. So we have 3 great cases. I, too, want to thank Dr. Íñiguez-Ariza for putting these together, and we'll see if we can keep them moving forward. As Mark said, there's no replacing Mike Tuttle, but we'll see if we can substitute for a week and have fun. And I do want to thank TIRO for keeping a picture of me from when I was 17 as my
We all thank them. We all do.
I do want to have the illustrious panel kind of introduce themselves. I'm going to go around my screen, and I'll start with Dr. Girshman.
Good morning, everyone. Jeff Girshman. I work at Memorial Sloan Kettering as a radiologist, special interest in thyroid cancer, head and neck cancer, but of course, in that big institution, we're involved in many different research protocols. And I did my fellowship at Brigham years ago. And Erik, this is the way I always picture him, and he looks exactly the same. So I don't know what he's talking about.
There you go.
Thank you for having me.
Dr. Robenshtok.
Hi, so I'm Eyal Robenshtok. I'm an endocrinologist from Israel. I did a fellowship in thyroid cancer in Memorial Sloan Kettering with some of the team here. And now I work in Rabin Medical Center in Central Israel.
And Dr. Lee.
Thank you, Erik. My name is Ting Lee. I'm a nuclear medicine physician at the Molecular Imaging and Therapy Department at Austin Health in Melbourne, Australia. And my role, I guess, is where we run a busy thyroid cancer clinic and actually we manage our own patients as well here. So I look forward to joining this panel. Thank you.
And Dr. Worden.
Hi, Frank Worden. I'm a medical oncologist at the Rogel Cancer Center at the University of Michigan. I specialize in head and neck cancers and endocrine tumors, and I am the protocol chair committee lead for the International Thyroid Oncology Group.
And Dr. Ghossein.
Hi, good morning. My name is Ronald Ghossein. I'm a head and neck pathologist at Memorial Sloan Kettering Cancer Center in New York City.
Well, thank you to the wonderful panel. Let's just jump right in. Dr. Íñiguez-Ariza, I'll have you kind of lead forward with the first case.
Perfect. Let's start. Okay, let's see. So the first case is a 43-year-old woman. She started with a slowly progressing increase in neck size, anterior neck. She presented with a thyroid nodule at age 27. Then it slowly grows. She was told it was a cold thyroid nodule. Eventually, it grew to the point that she was evaluated at an outside institution, and she had a total thyroidectomy. It was reported as a follicular variant papillary thyroid cancer, 8 centimeter with necrosis, and 1 parathyroid lymph node with metastases. For some reason, she did not get radioiodine. She was treated with neck radiotherapy, and she had the next 6 years, she was intermittently followed up with ultrasound and CT, but she received no further treatment, apparently only by a surgical physician.
And Eyal, let me just kind of level set and bring you in. Certainly a 43-year-old woman is kind of your average typical patient who might present with a nodule or whatnot. But just give the big picture on the size of this tumor. What does necrosis mean? How are you kind of viewing this from the start if this kind of came into the office?
Okay, so some things are more encouraging and some things are more worrisome. So first, she knows about it for a couple of years, so probably it's not very rapidly growing, but it is large. So the size, 8 centimeter follicular variant is extremely unusual. Usually it's very, you see it in the neck, it protrudes, it cosmetically interferes with how people see themselves. So usually we don't see this size of tumors. And there's necrosis. Necrosis can be a sign of aggressiveness. For example, for poorly differentiated thyroid cancer, we'll look at mitosis and necrosis. But sometimes we see it after FNA. There's an area of necrosis. So we need to think about these two things. Now, in this type of cancer, when we take this tumor out, the most important thing I want to know after surgery is thyroglobulin, because I want to know if it's something only in the neck, and then after surgery, thyroglobulin 3, 4, 5, or is it a metastatic disease, and then we will see very high thyroglobulin. So that would guide the next step. If thyroglobulin is very high, we would do imaging, and then we would treat with radioactive iodine.
Excellent. And Mark, I'm going to have you do the impossible and try and put your mind in the head of another surgeon. But most people, when they hear thyroid cancer, especially papillary carcinoma, will say surgery and radioactive iodine. And here, this is really external radiation when I see 5 fractions, 20 gray. What would prompt a surgeon to think that way instead of radioiodine?
Yeah, so, I think 2 things. One is if the surgeon had concern that, which I'm not, it's not clear whether or not that was the case here, but that there was residual disease that the surgeon was not, did not feel comfortable that he or she'd be able to go back into that neck. But I'm just wondering if the necrosis was a driving force here in deciding to go with external beam. And so, but aside from all of that, I think that's probably what was the driving decision point here.
Yeah, thanks. Let's keep moving forward, Nicole.
Okay. So, and basically, she was referred to our institution in March 2024, and then it was preceded by the fact that in December at age 42, she noted again an increase in size of her anterior neck. She visited an ENT doctor, and they did a chest CT. They saw some pulmonary nodules, so she was referred to us. In retrospect, she already has some intermittent dysphagia since 2019 and some shortness of breath, especially when she lied down, and that's why she was referred to us. This is the ultrasound. You can see here the big mass here on the right side, and she had some residual left. I mean, even though she had apparently a thorothyroidectomy, she had this on her left side, and this is basically how the image. This is how it looks by ultrasound. It was not very vascular. It has some calcifications, and it had this cystic lymph node on level 2. And also, as you can see, the CT, she had this very large tumor that was displaced in the trachea to the left and compressing the esophagus. And she also had this pulmonary metastasis. One was cavitated, which might suggest that this one grew faster than the other ones, at least for a bit. And
let me have you go back a little bit if you can, and I'm going to pull in
Yeah,
Jeff
perfect.
to the ultrasound image first. On the spectrum of masses you see on ultrasound and lymph nodes, Jeff, talk us through these.
Yeah, this would be on the higher end of the spectrum. This is clearly regular tumor, and obviously postoperatively can't be anything else but that. Very heterogeneous, just, you know, taking over the planes and growing the way it wants to. The image on the left, it looks to me like just regular thyroid tissue, and sometimes there's some left behind, and it can grow and it can be benign. The vascularity, you know, tumors vary greatly vascularity-wise. The follicular tumors are more vascular in general than papillary, but this looks like nothing like a papillary at all. The one thing that does speak for papillary is the nodal metastasis. This is a typical nodal metastasis in the sense that it has cystic features, which is commonly seen with papillary cancer. It can be seen with other things too, squamous, of course, but the entire nodal architecture is destroyed. It's now rounded, lobular, instead of the normal reniform shape, and there's no hilar vascularity that we'd expect. Now, as far as vascularity of nodal metastases as opposed to thyroid nodules, it is helpful to us when we see a node that's not as absolutely bizarre and metastatic as this one is. If it looked more like a regular reniform and it actually had normal architecture in a sense, and it wasn't too large, it was borderline, we can see, or it would push us a little bit toward being suspect tumor involvement when we see the peripheral vascularity. The tumor grows from outside in, and in fact, a lot of people report the absence of the central hilum as a strong sign that there's tumor. But before that even happens, that's the last thing to go. First thing is that peripheral vascularity. So if you can imagine a lymph node of peripheral vascularity, that's something I'd want to investigate further. But yeah, a neck mass like this is a tumor, especially in this setting with postoperative.
Yeah, and certainly a lot of disease here that we see. And just to the next slide, any comments you'd like to make on the CAT scan as well?
Sure. So this is the large mass, and with contrast on board, we can see that a lot of it is necrotic. It's not enhancing, but it's certainly vascular, and it's in the mediastinum. It's compressing the esophagus, which is here, and the trachea. And this is pretty strong compression. You know, she did have some issues, I know, with dysphagia, but you can see that we lose the trachea here as well. So I don't know if she had any difficulty breathing. These are clearly metastases when you see a multiplicity of rounded nodules in the young woman with a cancer diagnosis. They're invariably metastases. Regarding this one, which is the unusual one, in the sense that it is cavitary, if it was a standalone and she was immunocompromised, we can say, well, maybe it's fungal disease, maybe it's IPA, invasive pulmonary aspergillosis, but it's lacking that nice halo sign that a lot of the times it has, which is basically bleeding and edema around the fungal infection. But the constellation of findings, obviously, with this mass and multiple solid pulmonary nodules, this is just a cavitary nodule. Again, it's unusual in the setting of thyroid cancer. We more often see with squamous cell carcinomas that cavitate.
That's great. All right, Nicole, the next slide, I'm going to have you just kind of stop after the first bullet, but go ahead and introduce that.
Oh, okay, perfect. So she had an R2 tumor resection on May 2024, and we.
And let me actually just stop there. Mark, for those who just don't know, R0, R1, R2, what's the commonality of the language here that we're trying to convey?
Yeah, so it really goes back to R0 is a complete resection. R1 is microscopic residual disease, and R2 is when there's gross residual disease left in the bed here.
So hard resection, a lot going on, certainly dangerous disease still that persists. And Nicole, finish out the slide, and then we got a lot to talk about and pull in a few.
Okay, so we on pathology, the tumor was described macroscopically as the tumor in right central dissection as a 9-centimeter mass, and on microscopy, the tumor was not a follicular variant papillary thyroid cancer as it was referred in the past. It was actually this rare type of thyroid cancer, morular cribriform thyroid carcinoma, and it is consistent with has been reported in immunohistochemistry. It is TTF1 positive, PAX8 positive, thyroglobulin negative, Ki67 positive. She did have this selected mutation evaluated, BRAF, V600E, KRAS, and NRAS, and they were negative. Only the KRAS was positive. And here you could see the microscopic images. On the top, this would be the crypts, I think, and these are the morals, and this is the Ki67. And I'm just gonna go this forward, and this is the immunohistogram. It is TTF1 positive, as you can see, cyclin D1 positive, PAX8 positive, and it is described, and it is here also seen that it is estrogen and progesterone and estrogen receptor positive.
All right, back to the pathology. So we put it up in front. Dr. Ghossein, we got a lot to go through here. I'm going to ask the question that maybe some on the webinar might be asking themselves, which is, can a tumor evolve? Should we assume that this was a follicular variant, a papillary, and then it converted into a cribriform morular disease, or it was kind of a call that wasn't accurate? And go back one slide if you can, Nicole, and Ron, I'll pull you in.
Okay, no, I don't think a follicular variant can transform into a cribriform morular thyroid carcinoma. Actually, in the WHO, we separated cribriform morular from papillary carcinoma because it's really the molecular biology is very different. While papillary carcinoma, a disease of the MAP kinase pathway, the cribriform morular thyroid carcinoma are disease of the Wnt pathway, in a sense that they don't have BRAF mutation, very rarely RAS mutation. And the problem with cribriform morular thyroid carcinoma, we don't know if they pick up radioactive iodine or not. That's the big question. Now, to have a cribriform morular thyroid carcinoma that is on top of that high grade, talking about rare stuff, we saw one case at Memorial, and there was one case reported by Cornell, I think, university just next to me. Unfortunately, I don't have the beta-catenin stain, which is crucial, because the beta-catenin stain will really decide whether it's cribriform morular. But according to the report, the staining is the typical one. Now, the value of the cribriform morular thyroid carcinoma, that it can be the first manifestation of familial adenomatous polyposis, because when the gene for that disease is disrupted, the beta-catenin is accumulated in the nucleus. So yeah, I don't think there was a mistake in the initial report. I also would be very interested to know if in the initial thyroidectomy, the tumor was multifocal or not, because if the tumor is multifocal, this is a sign that maybe the patient has a familial adenomatous polyposis. And
Ron, on that kind of spectrum, you were saying earlier, obviously this is high grade, and we'll just point out that Ki67 index is pretty high. Is that fair to say?
Yeah, it is high, but we do not diagnose high-grade lesion based on Ki67, but on mitosis and necrosis, because in our study that I did here a long time ago, the early 2000s, mitosis did not correlate very well with Ki67.
Excellent. And just the question for the listeners as well, you'd mentioned this kind of as a package is quite a high-grade cribriform morular carcinoma. But you mentioned it can really be on a spectrum. I guess that's my question to lead you is, are all cribriform morular carcinomas considered a high-grade lesion or perform badly?
Not at all. Actually, the vast majority, the immense majority, are indolent lesion. And the value of this entity from a diagnostic point of view is that it, again, as I said, it could be the first indication that the patient has familial adenomatous polyposis. In a sense, the thyroid tumor in this patient can save their lives because they can get screening, and we had cases like that. Yep. She presented, the tumor started around 25 or 26 years old, 27, and that's typical of the one that are related to FAP, but you can have sporadic also cribriform morular thyroid carcinoma.
No, absolutely. So Ron points out excellent points. There's a real spectrum here. I'll even share, I had a case 3 weeks ago of a 17-year-old who came in, ended up with this in the thyroid, quite isolated, and seems to be doing no evidence of spread, but indeed went for colonoscopy and had 67 polyps throughout the colon. So its signal as a link potentially, not always, but a link potentially to FAP is so important. So let's have you keep moving forward, Nicole, to keep us on time.
Yeah, perfect. I just wanted to add that it is beta-catenin positive, and she did had a colonoscopy, no polyps, but she doesn't have yet an APC germline mutation assessment.
Very good.
So after surgery, you can see this is what was left of the right. It's a 2.3, not very well defined here, tissue. And these are the pulmonary metastases. She did have also an FDG PET CT, where you can see that this nodule especially is more as FDG avid.
And Dr. Lee, I'm just going to quickly pull you in on that PET scan. And just any quick comments on this, and also, can you just give a quick review of how we should think about SUV kind of numbers?
Thanks for that. Firstly, SUV, high SUV, I mean, it just means that there's a lot of intensity in the tumor. It does not necessarily differentiate between the malignant or even an inflammatory lesion can have extensive, quite very high SUVs. But in this particular scenario, of course, the fact that the SUV is so high in that particular lesion, and there are also a couple more FDG avid lesions, I think, in the chest. Is that correct? That, you know, would point towards the tumor being more aggressive in these particular lesions, and having that degree of dedifferentiation compared to iodine avid component. I think what you showed in the neck with the CT, and as Ron mentioned, you know, we don't know what the radioiodine status of CMV is, so it'd be interesting to actually have a iodine scan to see what that shows as well, and maybe you've got that differential disease present.
And Nicole, let's go to your last slide with some of those important questions.
Yeah, I just wanted to add here. We did like a local tumor board. The most reports don't suggest that these tumor express NEAS, the sodium iodine importer. So we haven't treated her with radiation. We do not have like a diagnostic scan. So the questions that I was wondering was, what should we do treatment-wise? Have you had any experience with this type of thyroid cancer? And since this thyroid cancer is usually it usually slowly grows and with good prognosis, there's not much information of what to do once it has spread distantly. She is stable for now, so we decided just to watch for now and see if it progresses. We might do something, but I was wondering what everybody thinks.
Just a few targeted questions to the unknown questions. Eyal, I'm going to bring you in. You know, we each have a handful of these. Radioiodine, what's your norm on this?
So there are only case reports. We don't really have data, but if you look at the molecular level, the likelihood of response is really, really low. So I see patients from all over, some get it, some don't. We don't expect the patient to respond in this case.
And also Dr. Ghossein, you know, pointed out that a few years ago, they kind of carved out, this isn't even called anymore, I believe, cribriform morular thyroid carcinoma. It's just cribriform morular carcinoma. It's unique genomic kind of world. But what always struck me is the staining and molecular kind of profiling is that it's thyroglobulin negative. So my other question, Eyal, is when you follow these patients, is there any role in our usual kind of serial thyroglobulin measurements in the serum?
No, there's no, and it's pretty frustrating. So we follow with imaging. In this case, PET-CT will be the best one. And it's challenging not to have a simple blood test like calcitonin or thyroglobulin when you follow the patient. Even antibodies give you something. In this case, we don't, it's just imaging.
All right, Dr. Worden, we always do our best in endocrine and then it doesn't work and we end up with the medical oncologist. So I'm going to pull you in just a minute or two. I don't know if there's a lot to say, but how do you think about an advanced tumor like this? And if it were
Yeah.
starting to anatomically progress, what would you do?
Yeah. No, it's really interesting, Nicole. I have a patient just like this, about the same age. So the screening for FEP, yes, is most important here to look for a colon cancer. But in terms of the thyroid cancer, I agree. You talked about how she relatively is asymptomatic. So watching her, I don't think is unreasonable. Some of these more intense lesions, if they're growing bigger, for example, compared to the other ones, you could consult radiation oncology, or if you're concerned about one of these lesions invading an important vital structure, maybe focal radiation would be warranted. Treatment with multi-targeted kinase inhibitors could benefit as long as we're not concerned about a bleeding risk. There is that cavitary lesion there. So I may consider, radiation to that prior to a TKI. Interestingly, she has ER positivity and PR positivity. So I may consider treating this patient similar to we'd treat an ER positive breast cancer. I don't know that we have data for that, but it would be an interesting, thought to see if that. And my question to Ron is, how often do we see that in these particular cancers? Is that something that's common?
Sorry, can you repeat the question?
The estrogen receptor positivity was noted in this case.
Yeah.
And so how often do we see that in these particular tumors? Do you see that often?
You mean thyroglobulin positivity? No.
No, the ER positivity.
Very common. Very, very common. All of them have actually, it's a kind of a condition to make the diagnosis. Yeah, usually they all are diffusely positive for ER/PR. Yeah.
Right. So thank you for that. Again, because my case of one, I didn't really know that. So I'll have to make sure our pathologist has done that. But then in that case, since it's diffusely positive, I probably would consider treatment with something like tamoxifen or other anti-estrogen based therapies.
Yeah, that's great. All right, we took up half our time here with the first case, so I'm going to
Okay.
keep moving forward. And Nicole, let's go to the second case if we can.
Okay, perfect. Thank you. This is some reference for the first case, and this is a case report of a partial response with lenvatinib that we could also consider. Okay, so case two. Case two is an 85-year-old woman. She presented with a rapid tumor growth on her neck. She had an FNA. It was an anaplastic thyroid cancer. She got a an XCT. It reveals a right necrotic tumor with gross calcification and invading structures locally, regionally. And she was referred to our institution in July. On the initial PET scan, you can see this tumor that is very FDG avid. It extends posterior to the hyperpharynx. It has bilateral lymph nodes with increased SUV positivity.
Stop there just for a sec. So Dr. Worden, I'm going to pull you in again. Anaplastic thyroid carcinoma comes, into different physicians in different ways, but we often direct them pretty quickly to see the medical oncologist. And so can you just kind of level set too, what's the workup? What's the standard kind of test that you're going to order to get the big picture of a new diagnosis of anaplastic carcinoma?
Yeah, and I think she's going to talk about this, but the most important thing is we know a lot of these tumors arise from a differentiated component, and some show up with these de novo anaplastic or undifferentiated tumors, which probably have transformed very quickly. So looking for driver mutations, in particular BRAF. So when we look for BRAF, we know now that BRAF inhibitors and MEK inhibitors respond extremely well, or these tumors respond extremely well to these agents. So that's the first thing we want to know. And if the patient is positive, we want to get them started on BRAF inhibitor and MEK inhibitor right away.
Are you able, just with an aspiration alone, to do that level of genomic analysis? Or are you going to pull in Dr. Urken and say, I need a piece of tissue to really get better analysis on this?
So if the pathologist can do IHC staining to get the BRAF, we will push to do that if there's enough tissue. We always like a core, because if it's BRAF negative, then we would look for other driver mutations such as ALK or NTRK or RET perhaps that may have some advantage. They don't quite do as well as with the BRAF patients, but we would want to know what that main driver mutation is. So we would want to core that.
And sorry to keep peppering you, but we get a PET scan on everyone. We get a CAT scan. Do you need an ultrasound? What's your imaging just to make sure you got all your staging and whatnot done?
The first thing obviously is, management of the airway and all that with the surgeon and perhaps radiation oncology, but a PET scan would be fine. We know these aren't cancers that are going to take up iodine, even if there is a differentiated component. So we would want nothing more. A PET scan will also tell us if there's metastatic disease, because if there's local disease, the next step would go to the surgeon. Can we resect it? If not, then chemoradiation, but surgery, chemoradiation, we can do so. And then we consider, adjuvant treatment in certain cases in conjunction with the BRAF inhibitors after we've given them in the neoadjuvant setting. Now, if it's metastatic disease, then we want to manage the patient locally while also treating distant disease, but not as intense perhaps with local treatment because of the metastatic component.
Excellent. Dr. Lee, just one other comment. Anything to say on that PET scan? Anything that jumps out?
Apart from the obvious mass in the neck and mediastinum, but also the bowel, yes.
Great, excellent. And I can't help myself, Dr. Urken. He said we consider the airway resection. If someone walks in the door with a new anaplastic, how are you thinking about that? And maybe you can also comment on how things have changed in 10 to 15 years. I think there was a lot more upfront surgical consideration then than there is now, given the neoadjuvant kind of world we live in.
Yeah, great question. So back in the day, surgery was considered if we thought that imaging supported that as a reasonable undertaking, except in select circumstances where there is an early ATC. We'll be very reluctant to operate until initial therapy has been administered. And so if the patient is fortunate enough to be BRAF positive, we'll wait until running the course and then offer surgery if we get a good response.
Agreed.
And actually, Frank, while we're on that, does it have to be BRAF positive? Is there any other mutation kind of scenario where neoadjuvant therapy is still in play?
So it's a good question, Eric. The answer we really don't know. A couple things about this. So we, Mark Cefario, but we were members, MD Anderson, some other centers with using immunotherapy and BRAF inhibitors up front, neoadjuvantly, which we saw a much greater response. So that would be important from that perspective if it's BRAF positive. Now, other mutations, RET, we also conducted a study looking at selpercatinib, including medullary as well as anaplastics. There are far fewer anaplastics that have RET driver mutations, but that could be considered. I've treated some of these people with Entrek, with larotrectinib, for example, and they have to have Entrek driver mutation. However, those patients respond, but the duration response is not quite as good. So other agents such as immunotherapy and radiation would play an extremely important role in such patients.
Yeah. Okay, let's move forward, Nicole.
Okay, perfect. So she also had a distant metastatic disease, but the main aggressiveness was local regional. You can see here the tumor here on the right. And so it was considered to be unresectable. She did have a BRAF mutation assessment. It was positive. So she was started with the dabrafenib trametinib at the usual doses up front. She tolerated very well. And at 1 month, you can see here the tumor response. The tumor decreased in size and FDG ability. The metastatic disease also improved. And at 3 months of structural response, resectability could actually be pursued.
All right, hold on that for a second. Actually, go back 2 slides if you can. Jeff,
Yeah, of
just
course.
help us out if we're just a typical endocrinologist trying to look at the trachea and see it kind of pushed in on. Is the anatomic compression correlate to imminent airway danger?
It could. I mean, this is widely patent. So although it's deviated markedly to the left, it's widely patent. And this is, at this level, this is the normal appearance of it. But down
Very
here, I would suspect no compromise.
Very good. All right, and back 2 slides to forward here. So at 3 months, structural response was seen and resectability could be pursued, Dr. Urken. when do you resect? How do you know whether to move forward with this continuously, continue the treatment, stop it, and resect? What's kind of your approach to that neoadjuvant next step?
Yeah, so imaging really does help in figuring out when the disease has reached a reasonable level that you think you could you can safely resect. If as long as there's not airway involvement, then somewhere in the range of 3 months is when we'll go ahead and go in. These surgeries are often not easy. Things are quite scarred, but very doable. And usually the answer to your question, usually at 3 months. And the question becomes whether or not one needs to do a total thyroidectomy in a case like this, whether that contralateral lobe needs to be operated on, especially if the vocal cord on the ipsilateral side is compromised.
That's great. And Frank, what's the response you see in this for the BRAF positive neoadjuvant durvalumab trametinib? How often do you see this kind of excellent kind of first step here?
Yeah, we see it a lot. It's interesting when you look at that basket study that was published that actually ultimately got the D+T approved by the FDA. It was from 54, 56%. But if you go to those who have been to ASCO or are interested, go to the ASCO website and look up Mark Safario's abstract, where we gave pembrolizumab in combination, and the response went up to 73%. So personally, we don't know if D+T pembro versus D+T, is there truly a benefit there? But it does appear that the immunotherapy is offering benefit. And then, like Mark said, we bring them to surgery at 3 months, and then it was pembro and radiation therapy afterwards, followed by pembro and then D+T. The D+T should be continued as long as the patient can tolerate it, because that really is what's taking down these tumors, and on the distant level as well.
And so if I'm hearing you right and connecting you with Mark here, 3 months is kind of a standard with the D+T, maybe surgery, but you'd continue the D+T through that kind of secondary resection. Keep it going.
Absolutely. After we consider adjuvant radiation therapy, because we wouldn't do it yet in combination. We don't have data for that. But after we finish the radiation therapy, yes, we would give immunotherapy for up to 2 years, and then the D+T would with D+T, and then continue the D+T continuously, indefinitely as tolerated.
That's great. And Nicole, the next slide, I think there's some pathology here. I want to pull in Dr. Ghossein.
Yeah, perfect. So she got a thoracic resection with central and bilateral lymph node dissection, and the surgeon did notice like the tumor was kind of jelly-like. Pathology confirmed this tumor liquefaction. Apparently, it was only 5% of the tumor had viable ATC at 1.4 centimeter and 1% in the central lymph node dissection. And you could see the precursors. The papillary thyroid cancer was found bilaterally, with the largest tumor being 1.2 centimeter and many metastatic lateral lymph nodes.
All right.
Yeah, so here is the macroscopic image. You want me?
So actually, go one previous, Dr. Ghossein, just 2 comments. Liquefaction, what does that mean? And then the second really is, we do increasingly get these reports that suggest a percentage of the tumor has converted to anaplastic. Does that mean anything? And is the cat out of the bag once even there's a portion that becomes anaplastic? How do we think about that?
Yeah. So liquefaction, I mean, we don't use this term in North America, but I guess it's meant that it's just probably in necrosis. Now, regarding the anaplastic carcinoma, how much of the, you have here a 5% residual. I don't think we don't have yet good really protocols to assess the percent of response like you have in breast. For example, I think the team at MD Anderson is going to work on it. We're gonna try also to work on it. So I cannot answer the question, what exactly does it mean, the percentage, because I don't know how they calculated the percent. Nobody knows how, everybody does it differently. Now, what I found interesting here, that there is papillary carcinoma that has survived the treatment, and which is typical. The anaplastic respond, and paradoxically the papillary carcinoma does not respond. And the thinking here, at Memorial, it's probably due to the immune response that is much higher in the anaplastic than the papillary carcinoma.
And, you know, Frank and Eyal, I'm going to pull you both in. When I also, in kind of a separate world, will consider D plus T for redifferentiation therapy, I have to ask the question for the audience. Has the radioiodine question, is it ever still on the table in anaplastic or simply not an option?
So there are rare cases where we see complete remission from anaplastic. When you find a mass, you take it out, and there's a surprise diagnosis of anaplastic, and sometimes you have complete remission only then. And it's also in the guidelines of the anaplastic thyroid carcinoma. There's no role for radioiodine unless you have complete remission from the anaplastic.
Yeah, and I don't think we're going to get there in this case, but Frank, any comments on top of that?
Yeah, I mean, I would say there's no role for redifferentiation at all, but I will agree. We're actually curing people, and with this cancer where this was not heard of years ago. And I
Absolutely.
do believe, even though we don't have randomized data yet, the D plus T immunotherapy versus D plus T, that based on the new keynote study in head and neck cancers, or even in melanoma, when you give the immunotherapy before surgery, when those lymph nodes are intact, I do believe that will translate into a long-term benefit for these people.
That's great. Nicole, let's move us forward here.
Okay, so here you could see, this is a left lobe. You can see the necrotic area here, and the white tissue here is apparently the papillary component. Here on the microscopic image, you can see necrosis, and here the anaplastic component. Here you can see on the top the ATC with this cells that look horrible, and then down here you can see the papilla and the typical changes of papillary thyroid cancer. And this image is actually, it has both. It has the papillary thyroid cancer here on the left, and to the right the ATC, and that's basically the pathology. And later, after surgery, she had a IMRT to the neck, and D plus T was resumed after completion of radiotherapy, and immunotherapy was added. She has 3 doses so far, and on follow-up, you can see that there's some residual disease, but it's not much. And basically, let's see. She also has, as you can see, the lung metastases do seem to be from the differentiated component. She also had, since the first FDG PET, this avid sigmoid FDG avidity here in the sigmoid column, and that has improved with treatment, the avidity with the treatment for the anaplastic. And so she had a colonoscopy. She has this tumor. It seems she has it is an adenoma with high-grade dysplasia, but it seems she has a second primary here. Since the anaplastic was driving the prognosis, this is going to be treated soon, probably this month.
Now, hold on that for just 1 second. Eyal, have you ever seen a thyroid cancer metastasize to the lumen of the colon?
No.
I have not either, and I don't know if maybe
Yeah.
Frank has, but in general, I
have
just want
not.
to point that out.
I just want to say something. The radioiodine is obviously not for the anaplastic carcinoma. It's for the background of the papillary thyroid that they have in the background. No, not for the anaplastic, just to make the point.
And go back 1 slide, Nicole, if you can.
Yeah,
Dr. Lee, on the PET scan, any thoughts, comments, and also how much do you look at changes in SUV values before and after treatment as an important prognostic piece, or is it all anatomic disease and change in size?
Is
Who
that
are
a
you
question
asking?
for me?
That's for you, Dr. Lee.
Okay, thought it might be. We probably practice a little bit differently in Australia, where we don't necessarily go with the SUVs, as you may have noticed. We don't use that as a prognostic marker per se. And it is looking at the response that you may or may not have on the actual PET scan as you have here. It looks like it has responded very well. We'll need to have a look at the cross-sectional images to see whether that that pulmonary nodule that you showed on the CT is actually what is FDG avid or not. And that, I guess, could potentially guide whether we give radioiodine or not.
Excellent. And go forward, Nicole, your last slide, I think, with a few questions.
Yeah.
Okay.
So basically, the questions I wanted to ask the panelists was, this patient is from she's uninsured. It's been hard to get D+T, but she's been able to get it for now. And so we will probably have to stop it if we don't get, we were able to get trametinib for her and the immunotherapy, but the brafenib, she would have to get it out of pocket. So we don't know if they're going to be able to pay it. So what should we do next? Then for the pulmonary metastases, the pulmonary metastasis have been stable, and they don't have they have low FDG avidity. So we were wondering, after treating the colon cancer, if we should give a dose of radioactive iodine for the pulmonary metastases. And
I'm going to stop with those two questions for
Yeah.
this time. And Frank, I'm going to give you a minute or two, just general thoughts on those hard questions, if you can.
Yeah, so I had mentioned earlier, yeah, Nicole, continuing the D+T would be, ideal. I mean, we run into this as well. And obviously in Mexico and different countries, but things are different. Sometimes sponsors or companies will provide free drug programs. Interestingly enough, I don't know if it's available, but things like encorafenib and vimetinib, which are also BRAF and MEK inhibitors, have activity and maybe are available, to such patients if D+T is not. So that would be something that I might look into.
All right, let's keep us moving, Nicole, to the third case. And we have 14 minutes. There's
Okay.
absolutely a lot of advanced disease in Mexico, Nicole.
Yeah, it seems. So this is a 41-year-old woman. She prior to presenting, she referred back pain for 4 years. She had some simple X-ray, nothing showed up. A year prior to her diagnosis, she started with some left upper abdominal pain, not very strong. In October 2020, at age 37, she had a COVID test that was positive, so she decided to get a CT scan, and she was actually asymptomatic. And on the CT chest, there was a T8 tumor, 8.9 centimeters. She got an MRI, and it was infiltrating the adjacent ribs, pressing the pleural space and causing lung compression. So it was thought to be a primary bone tumor. So she had an aggressive surgical resection at a different institution, and the pathology showed a follicular variant papillary thyroid cancer, TTF1 thyroglobulin positive, 9 centimeter with lymphovascular invasion, and these two mutations were assessed, BRAF, V600E, and KRAS. They were negative. And so that same month, she got once they knew it was a thyroid origin, she had a total thyroidectomy. She had also follicular variant papillary thyroid cancer, 2.5 centimeters, no lymph nodes positives.
All right, and hold right there. Dr. Ghossein, I'm going to pull in what I think Eyal and myself will be asking, but we would walk into our tumor board with our pathology colleagues and say, wait a second, a papillary carcinoma we always learned is kind of local spread. We'd expect to see some lymph node involvement if there was a big lesion. And in fact, it's follicular thyroid carcinoma that tends to be more bony mets. Is there a crossover? Is there any complexity in calling these out in terms of their microscopic appearance, or what do you think on that?
Maybe Ronnie,
yeah, it's a very good question, and we did many studies at Memorial, and I did study with your colleague, Dr. Barletta from Brigham. So basically, the follicular vent of papillary carcinoma is two diseases. There is the encapsulated follicular vent that this patient has, that it has the name of papillary carcinoma, but forget about it. It's not a papillary carcinoma. It's a RAS mutated tumor. It's basically a follicular carcinoma with clear nuclei. And we are trying to change the name. That's why actually when there is no invasion, we call it NIFT-P. So these actually, and it's interesting to see here that they don't go to lymph node, they bypass lymph node and go to into a distant site. So you have to look, as a clinician, you have to look at the encapsulated follicular vent as a misclassified entity that's just another form of follicular carcinoma. It happened that the nuclei are clear. So that
And
is
is
the
this,
mentality.
is this a parallel, similar but different, when occasionally we can get a follicular adenoma, maybe miss the invasion, and sometimes they pop up down the road with a distant metastatic site as well?
Yeah, so this is the other interesting things about this case, is that according to the report, although I did not look at the slides because there's enormous inter-observer variability when it comes to diagnosing capsular invasion, but we have done a study once at Memorial, and we thought that we found out that the encapsulated tumor with minimal invasion, when they have distant metastasis, like this case, is almost always at presentation. And it's interesting that the case has fibrosis, because we have seen a lot of fibrosis in this case, and maybe it was a regression phenomenon like you see in melanoma. So yes, it is possible to have distant metastasis with minimally invasive tumor. Almost always, however, they are at presentation like in this case, and often they are RAS and TERT. Yeah.
Right, and I'm going to
Okay,
do the next
so
slide.
two
And
short points.
Eyal,
Yeah.
yes, please.
It's extremely important to know these two types of follicular variant PTC, because most physicians are not aware for the infiltrative type and encapsulated type, and they behave completely differently. And if you do like a lobectomy for an encapsulated tumor, it can be follicular variant or follicular carcinoma, we do encourage to check for thyroglobulin, just to see that it's not 800, that it's not 1000, even if we don't see vascular invasion, just once, to see there's nothing extreme there. That's it.
That's great. Nicole.
Okay, so she got her first dose of radioiodine 200 millicuries. The thyroglobulin was 110 in that particular time, and I'll show you how it has radioiodine avidity in the thyroid bed and in the lung metastases and in the area where the primary tumor was. Well, the tumor was resected. The metastases, that wasn't the primary tumor, was resected in T9. And she did have an FDG PET-CT with no abnormal FDG avidity. She got her second dose of 200 millicuries a year and a half after surgery. Here, the stimulated thyroglobulin, it was higher in 226. And here, she had a new lytic lesion in the frontal bone. So here you can see the first radioiodine dose. You can see how the lung metastases are avid.
Quite avid.
Yeah, and then this is the second dose. Here you can see the new lytic lesion radioiodine avid in the frontal bone, and here the area where she had the surgery.
So hold there, and Dr. Lee, I'm going to lead you on this one, but first of all, thoughts on the imaging, but number two is it more common, less common to see continued iodine avidity on the second treatment with radioiodine?
It depends on the location. You'd expect that if it was an effective treatment, the radioiodine should be less and get progressively less, even in bony metastases, which tends to be a little bit more resistant to radioiodine. But that's where you do the FDG PET to look for the dedifferentiation component, which I believe is negative here.
Yeah. And I just pull out that point a little bit. I mean, when we choose to give radioiodine, and we're doing less of it now, certainly over the last decade, but when we do, we often are thinking one dose. And even if we consider a second dose, I got to say the expectation on the endocrine side is that you're usually not going to see as much uptake, and you're going to certainly bring with it the sialoadenitis and other things. But you do get these unique cases where there's continued iodine avidity. And it's going to foreshadow a little bit, I think, the question some will ask, which is, if you keep seeing the iodine avidity as kind of this targeted then uptake, should you keep using radioiodine, or should we move to a more targeted approach? Let's not answer that yet for time, but keep moving us forward, Nicole, if we can.
Okay, perfect. So she was referred to the diagnosis of maybe a radioiodine refractory differentiated thyroid cancer. Her thyroglobulin at the time was around 300. She had an egg ultrasound, which was negative. She had the chest CT only lung micrometastases, and she had an FDG PET CT with this lytic frontal lesion. And on follow-up, the thyroglobulin increased to the thousands, and the lung was still stable, but she has this this lytic frontal lesion, now 3.3 centimeter with FDG ability. The brain MRI showed no brain mets. So she did get external radiotherapy to the frontal bone mets. The tumor decreased in size a bit, the frontal tumor. She was also started on zoledronic acid every 3 months. And she has developed new metastatic bone disease. Her thyroglobulin went to the 4,000s. She was treated externally for for the pelvis and spine. It has been very symptomatic for her. She has had multiple skeletal related events. She had pain in her left tibia, so she had this metastasis that I'm going to show you that was with increased risk of fracture. So she had surgery for that. She had a C2 fraction that was risky for the fracture.
Nicole, I'm going to move you forward to the genomics if we can, just for the sake of time here.
Okay, yeah, sorry. Okay, let me continue. And so basically, this is the frontal lesion. It progressed. She had this surgery here. She had eventually the frontal metastasis was removed. And this is the genomics. She got an NGS, and basically she has an R81 and a TERT promoter mutation.
And kind of a rare mutation, right? But certainly the dual mutation of anything with TERT catches our attention and classically affiliates with aggressive disease. What I'm going to do, I think next one is questions, maybe, Nicole, if you just go forward.
Yeah.
Okay.
She did get a third dose of radioiodine, and recently she had this symptoms. She had this psychotic episode, and after the dose of radioiodine and an FDG was done at the same time, she had this hyperdensity on the right that is actually cerebral edema. So it seems she has a new brain metastasis that is very large at 4.5 centimeters. So the questions would be,
all right, so hold there, and because I'm going to pose one last question. I know time's going to be tight here. There's a lot to talk about. And in fact, Frank, I'm going to pull you in, but pull out the last moment of the brain metastasis and the argument that there's imminent issues to deal with. But the question I think that's really intriguing in front of all of us is going to be this issue that there's continued iodine avidity, and yet there's anatomic growth. And how do we think about, again, repeated doses of radioiodine? I've heard some people say give inorganic iodine afterwards, see if you can trap the iodine into those lesions because it's very targeted and good. Or has the ship sailed and our newer TKI therapy here is so important and so valuable that we should really jump here to something different?
I'll comment about that. What worries me here is the brain involvement with the TKIs. So there's a risk for bleeding. So if we're going to consider treatment with TKI therapy, in particular lenvatinib, then we really need to make sure that the brain lesions are controlled either through surgery or radiation therapy. So I think anybody really who's starting these therapies should be checked to look for brain mets prior to treatment. In this particular case, that does take pause. It doesn't mean it couldn't be offered. The other thing too about bone disease, treatment with TKI therapy, it can have some benefit, but it's not as beneficial as someone who has visceral disease, such as lung disease or liver disease. In a case like this is somebody maybe I would consider, because of the aggressive component, like using actually cytotoxic chemotherapy. So the group from the Mayo Clinic reported a case series using carboplatin and pemetrexed, which I have used in such patients and had some responses to therapy. So that may be at the forefront versus actually using an anti-angiogenic.
That's great, and certainly a lot there. My biggest job, along with guiding a wonderful panel, is to keep us on time, and we do have 1 minute. So I want to take a moment to thank Nicole. Those were 3 great cases, a lot to talk about there. I want to thank an illustrious panel. Remember, if you're not happy with today or you're upset or have comments, my name's Mike Tuttle. But if you're happy, please send your comments to Dr. Urken or Dr. Alexander. And with that, I wish everyone a great day ahead throughout the world, and I thank you for taking the time. Thank you to the panelists as well.